So now we have our dynamic chairman ARC and a dynamic retina surgeon from Center of India.
Thank you, sir, for those kind words. So I would be taking you through this. We have already been introduced to Widefield angiography as well as Widefield OCT. This is a bouquet of cases, clinical cases, which I would be sharing with you to show how this system, why Widefield imaging is the need of the hour. So this all we know, and these are the types of cameras which we have already spoken about. So, and this is what we already see, and what in various types of ultra wide field and the amount of area in the retina which you can see. These are the options, the Optos, the Claris, the Mirante, Heidelberg, and these are various options which are available to us in the market, which are offering these wide field imaging systems. The Mirante has a unique advantage because it offers FFA, ICG, combination autofluorescence OCT, and also wide field OCT as well in this single system. Now let us see the first some clinical advantages with the wide field OCT. In a standard wide field OCT, the width, the length of the scan size is about 9 to 12 millimeter. While this system, it is almost 16 millimeter. And this is especially important if you are studying simultaneously the associated extramacular pathology, some peripheral regions, and when we are doing this, the image resolution is well maintained. Now this is some of the examples from the textbook. I will just show you a few of the cases from our hospital. Now this is a mother of a pathologist who has a peripheral PCV. You can see on a color wide field photograph, a large peripheral mount, and on an OCT, you can see this is a blown out picture, and on a wide field OCT, you can see the macula over here, and also the scan which goes through the peripheral lesion. And you can see the fluid which is percolating into the creeping into the foveal area. And this is the OCT which goes actually through the PCV lesion, where you can actually study the image well. And this was the left eye wide field OCT, where in a single go you see the optic nerve head, the fovea, as well as the peripheral part. And this is, in this particular patient, we treated the patient with brolucizumab as a single modality of treatment, and you can subsequently follow up this patient at 4 weeks, how the lesion is coming down or not, and without much having any invasive investigation, and you could see how it subsided with proper treatment. Now this is case number 2. Patient was diagnosed elsewhere as a case of epiretinal membrane and suggested surgery. At our center, when we repeated, you could see there was a membrane which was moving across, and this was the response. So there was this was just not simple ERM, this was a more of a associated fibrous tissue along with the epiretinal membrane. So it helps you in properly deciding the type of a management which you are going to do in this case. Now another case, patient diagnosed elsewhere as a case of a epiretinal membrane with a lamellar macular hole. Yes, it is true. But now look at the picture. You have a wider perspective, now your diagnosis changes. You have a tractional, there is a fibrous tissue which is pulling this and leading to traction. So this is tractional retinal detachment associated with schisis and lamellar macular hole. So it changed the way we look at this particular disease. Another case, diagnosed elsewhere as normal, and they thought there is a blunting of the fovea and some epiretinal membrane. Wide field OCT, you can see this is a peripapillary schisis. So the treatment here totally changed. You had to treat him with steroids and all. Now coming to few of the, Dr. Ajay has already shown you the utility of the imaging system in the diabetic retinopathy. It helps you in detecting especially the peripheral neovascularization, and it helps you in doing a targeted laser therapy. This is specifically important when you are doing a resistant case of diabetic macular edema. You are injecting multiple anti-VEGFs, but there might be a pocket of peripheral dropout which needs a treatment and which can avoid the need of further treatment. Now this is a patient who came with these photographs. He had undergone laser and was diagnosed elsewhere to have a capillary dropout, and there was a bleed. And look at the difference, stark difference. You can see so much in this image. You can see that in this case there was just scatter laser mark. This area was not covered adequately. This is the hemorrhage. In the left eye you can actually see the hemorrhages lying over here. And a wide field angiogram could show you that the dropout area was not necessarily only restricted to the posterior to the equator. The standard teaching is that proliferative diabetic retinopathy is a posterior pole disease. So that means we used to do pan-retinal photocoagulation only up to the equator. While this challenges our basic understanding of this disease, that yes, the dropouts can extend even anterior to the equator, and so is the need of extending your pan-retinal photocoagulation right from the arcade up to the ora serrata, at least in cases where there is recurrent bleed or in a case of a recurrent diabetic macular edema. Now similarly, in a case of a retinal vein occlusion, this is the picture where the patient was carrying, and he had bleed and all those things, and look at the how much extra information you are getting. Actually, you know the area where you need to do a sectorial laser, which has to be as extensive as that, and on a wide field you could see further. So this is what we learned from these few cases. Now this is another case who was 67 years old male who was advised to have diabetic macular edema. He was a diabetic patient. He diagnosed elsewhere as diabetic macular edema and was advised anti-VEGFs. Well, when we did a Widefield OCT, our way of looking at the disease was that I could see the sciatic cavities, even both the eyes, extending quite into the periphery. So it was not just simple diabetic macular edema, but this was a case of a macular edema along with a retinoschisis in a case of a diabetics. And when we look at the image, we really did not know, we did not see anything specifically. So we did an angiogram for this particular patient, especially in the right eye where the edema was there. We could see that there was an associated peripheral telangiectasia. So this associated peripheral vascular telangiectasia in a case of a retinoschisis was the reason for superadded macular edema in this particular case, and so we treated this particular patient with a laser in this peripheral area, and once we lasered it, the need of anti-VEGF could be avoided. Now this is a patient who was diagnosed elsewhere as a case of a partial retinal detachment, but when we saw on a field photograph, we thought we are seeing some fibrous tissue. We bothered to look into the other eye, which is very important. And here also you can see that there is a fibrous tissue here. So it was not just treating the eye which is symptomatic, but it is equally important. This picture teaches you why you should look into the other eye which is asymptomatic. And this is a case where we could do a Widefield angiogram, which is not possible to pick up this disease. So importantly, we treated the better asymptomatic eye with a laser and averted a disaster which had already happened in the left eye. Of course, we operated the left eye, and this is the post-op photograph of the same patient. Now this is 52 years old, diagnosed elsewhere as epiretinal membrane and was advised vitreous surgery. Now look at it. We did a Widefield OCT, and when we did a photograph, you could see that the blood vessels were drawn down, so they were being dragged. And so it was not just a case, it was again a case of FEVR with a vitreomacular traction, which meant you just did not need vitrectomy with a membrane peeling, but you also needed to dissect the peripheral tissue to take care of this disease. 48 years old male, systemic disease as quoted over there, diagnosed elsewhere as a case of Roth's disease. And when we did a Widefield angiogram, you could see the terrific shutdown in both the eyes. He was investigated and he was found to have a bilateral carotid disease, and this is how we could prevent a so-called morbid condition in this particular patient. Similarly, this is diagnosed elsewhere as ERM with full thickness macular hole, and when we did, this is the Widefield photograph, Widefield angiogram, and this is almost a half zone type of image which you can see in this particular case. This is 26 years female who was Montauk's positive and had a healed choroiditis, but she complained of progressive loss of vision, which we could not explain on the basis of healed choroiditis patches. So we decided to do a fluorescein angiography, and we could pick up a peripheral dropout, and we had to treat him with laser along with steroids. Other case, 48 years old male, sudden loss of vision in a healed choroiditis. Through this hemorrhage, we could do an angiogram, and we could see that there was a peripheral dropout which needed treatment. So as I can go on with this is the last case which I will share with you, an interesting case. Female diagnosed elsewhere as a Eales disease with combined, and was advised vitrectomy for combined retinal detachment. This is fine, everyone accepts it. But when you look into the better eye, which is asymptomatic, you can see on a Widefield photograph there is something called pruning of the blood vessels. When we did an angiogram for this particular patient and further systemically evaluated, this young girl had a Takayasu disease, so we treated the better eye before we touched the eye which was symptomatic. So this is how it changed my way of looking. Another last case, this is a girl, 19 years old girl who had a thumbsical right eye following some vascular tumor. Look at the family history. We looked into the better eye, asymptomatic. Even to the experience of 20 years as a clinical retina specialist, I thought it is normal. But that history, family history, and that history did not leave me comfortable. So I decided to do a Widefield angiogram for this particular patient and look at this multiple angiomas. Multiple angiomas and a case of a von Hippel-Lindau. So we treated this patient with LIO with triple freeze cryo, and you can actually document the whole thing. Look at this. Now, in a case whenever you have a VHL, you always need to understand there can be a family history. Look at a symptomatic father. Yes, on an angiogram you could pick up lesions which were lying. Again, a brother who was asymptomatic. Again, look at his angiogram, Widefield angiogram. We could pick up an angioma in both the eyes. We did naturally in this case treat both the things. But look at it, how Widefield angiography can be helped in such cases. 1 year later, the guy has some new lesions and some old lesions which are not treated. And so a repeat fluorescent Widefield angiogram was done. Of course, we did a genetic study and we could pick up the gene which was involved. But this is what we should learn. Widefield angiography in such cases can help you out. So my list can go on like this with multiple cases, the importance and the utility of Widefield angiography and OCT. But here I end my talk, and thank you once more for this opportunity, and thank you KLB Instruments for having this wonderful instrument with us in our country, and for this opportunity as well. Thank you.
Thank you, Prashant. I know you have to go to another hall. In the meantime, Shilpi, you can start your thing. So I think wonderful thing you highlighted, like what we missed, not seeing the periphery. So that's why in the screening, even though we do, Dr. Rajay is our chairman for AOS diabetic retinopathy screening, where we only take disc macula, but those patients don't even go for a retina photograph. But when we, as a retina specialist, I think we have to concentrate on both center and the periphery. Thank you.